Welcome to This Explainer. Today, we're unpacking the incredibly complex landscape of pediatric peripheral neuropathies. We'll be moving from core pathophysiological mechanisms all the way to the latest emerging clinical diagnostic modalities. Since we're all operating at a graduate or specialized clinical level here, you already know these conditions are highly heterogeneous. They demand a rigorous, evidence-based approach. So let's systematically bridge that gap between foundational neurobiology and the latest clinical data to build a comprehensive translational diagnostic framework. Here is our roadmap for today. We'll start with an overview of pediatric peripheral neuropathies, then look at mechanisms of nerve damage, followed by diabetic polyneuropathy in children. After that, we'll cover hereditary and genetic profiles, outline a multimodal diagnostic framework, and wrap up with clinical implications and limitations. So let's jump right into part 1, our overview of pediatric peripheral neuropathies. Let's quickly establish our anatomical foundation. The crucial takeaway here is that damage to any of these specific structures can result in polyneuropathy. The peripheral nervous system is a delicate, highly intricate network. When evaluating peripheral nerve damage, we aren't just looking at the neuron itself. We have to consider the axons and myelin sheaths, of course, but also the supporting architecture. That means the endoneurial and epineurial connective tissues and, critically, the vasa nervorum, the microvascular supply of the nerve. A pathology originating in literally any of these microcompartments can trigger a cascade leading to overt polyneuropathy. Clinically speaking, the presentation of these structural deficits shifts dynamically with age. In infants, the signs are typically broad and systemic. Think profound neonatal muscular hypotonia, delays in hitting major motor milestones, or even difficulties with basic primitive functions like feeding and swallowing. But as the nervous system matures and the child becomes more cooperative, the clinical markers become much more localized and mechanical. Older children will often present with a characteristic steppage gait, that classic foot drop, an inability to walk on their heels, or noticeable deficits in fine motor coordination, like struggling to button up a shirt. Recognizing this age-dependent phenotypic evolution is absolutely essential for early clinical suspicion. Moving on to Section 2, the actual mechanisms of nerve damage. Building on our anatomical foundation, there's a stark contrast in the differential diagnosis when we look at the underlying mechanisms. On one hand, we have acquired and metabolic mechanisms. In cases like diabetes mellitus, the damage is typically driven by external metabolic derangements. These cause microvascular changes, specifically endoneurial ischemia and subsequent nerve starvation. It's an acquired hit. On the flip side of the paradigm, we have hereditary and genetic mechanisms. Here, the pathology is intrinsic. It's driven by inherited gene mutations that directly compromise the development, survival, or myelination of the nerve fibers themselves. Determining exactly which pathway is driving the disease is really the foundational step in your diagnostic algorithm. Let's explore that acquired side first in Section 3, diabetic polyneuropathy in children. Now, a striking statistic in this field is just how prevalent subclinical large and small fiber neuropathies are long before overt, classical symptoms ever appear. In fact, research indicates that roughly 50% of children who have had type 1 diabetes for more than 3 years already exhibit subclinical signs of neuropathy. That's huge. This is a progressive condition rooted in progressive demyelination and endoneurial microangiopathy. Now, while pediatric patients rarely complain of the severe neuropathic pain we see in adults, these subclinical deficits in cardiovascular nerve function and peripheral nerve conduction actually start manifesting very early in the disease course. Furthermore, it's critical to realize that susceptibility to this diabetic polyneuropathy isn't purely metabolic. It is heavily modulated by genetics. Recent comprehensive genomic profiling has identified specific single nucleotide polymorphisms that significantly alter vascular risk. For instance, looking at the endothelial nitric oxide synthase, or eNOS gene, the T/T genotype in the T786C polymorphism is a major genetic risk factor for developing DPN, whereas heterozygosity actually appears to be protective. Similarly, in the angiotensin II type 1 receptor, or ATR1 gene, the presence of the C allele acts as a protective genetic factor. What this tells us is that microvascular ischemia in diabetic nerves is the result of a highly complex interplay between chronic hyperglycemia and the patient's baseline genetic vascular integrity. This segues nicely into Section 4, hereditary and genetic profiles. Transitioning over to the intrinsic side of the spectrum, we see a direct contrast to adult populations, where acquired conditions vastly dominate. In pediatrics, inherited forms represent a massive proportion of neuropathies. Current epidemiological data suggests genetic etiologies account for anywhere from 30 to 70% of all pediatric peripheral neuropathies. That encompasses various types of Charcot-Marie-Tooth disease and a host of other rare syndromes. Because this proportion is so remarkably high in children, our clinical and diagnostic algorithms have to be highly targeted toward capturing complex genetic variations early in the diagnostic odyssey. I know, the sheer genetic heterogeneity can seem daunting, but careful clinical phenotyping can beautifully guide our molecular analysis. Take hereditary sensory autonomic neuropathy, or HSAN type 1, which is a rare autosomal dominant disorder. By paying close attention to nuanced clinical markers, we can actually distinguish between specific gene targets before we sequence anything. Patients with mutations in the SPTLC1 gene typically present with prominent neuropathic pain. Conversely, patients with RAB7 gene mutations present with very similar sensory and motor involvement, but critically without the neuropathic pain. So a highly precise clinical examination literally serves as your first filter. So how do we put this all together? That brings us to Section 5, establishing a multimodal diagnostic framework. With such a complex differential encompassing both stealthy metabolic pathways and vast genetic variables, the traditional diagnostic funnel has historically relied on a standardized sequence. We start with a rigorous clinical history, move to electrodiagnostic studies like EMG and nerve conduction studies, then to targeted genetic panels, or, in rare, highly complex cases, an invasive sural nerve biopsy. Now, while EMG and NCS remain the gold standard for classifying neuropathies as either axonal or demyelinating, we have to acknowledge a major clinical limitation here. These tests are profoundly challenging, frightening, and physically painful for a pediatric patient. This frequently leads to poor patient compliance and ultimately technically limited or inconclusive results. This brings us to a really pivotal question in modern pediatric neurology and translational medicine. If our gold standard is traumatic for the child and sometimes yields limited data because of that trauma, how can we evaluate these delicate peripheral nerves non-invasively without sacrificing scientific accuracy? Well, the answer increasingly lies in high-resolution nerve ultrasound. This is a highly promising, non-invasive imaging modality that allows us to directly visualize the peripheral nerves in real time. By utilizing high-frequency linear probes, clinicians can quantitatively assess the nerve's cross-sectional area, evaluate the echo structure, specifically differentiating those hypo and hyperechoic linear structures, and map the distribution of any nerve enlargement. And the best part? All of this is done without causing the patient any discomfort whatsoever. The empirical evidence supporting nerve ultrasound is highly compelling, particularly in acquired conditions. Recent studies evaluating children with type 1 diabetes used ultrasound to assess the sciatic, tibial, and common peroneal nerves. The data is striking. It demonstrates that reduced differentiation of nerve echo structure combined with altered echogenicity offers an astonishing 100% specificity and nearly 72% sensitivity for detecting diabetic distal polyneuropathy in children. To put that into perspective, it means we can accurately identify structural nerve degradation entirely non-invasively, and it correlates directly with disease duration and patient age. But its utility goes well beyond metabolic conditions. Nerve ultrasound is proving absolutely invaluable in the genetic and inflammatory space too. By simply mapping the presence and the exact anatomical pattern of nerve enlargement, we can seamlessly differentiate underlying pathologies. For example, demyelinating forms of Charcot-Marie-Tooth and certain lysosomal storage disorders present with marked diffuse nerve enlargement. In contrast, chronic inflammatory demyelinating polyneuropathy, or CIDP, typically shows a diffuse but multifocal enlargement pattern. And crucially, axonal forms of CMT show absolutely no nerve enlargement at all. Gathering this morphological data allows us to bypass significant guesswork and target our genetic testing so much more efficiently. Finally, let's look at where we currently stand in Section 6, Clinical Implications and Limitations. As rigorous clinicians and researchers, we must openly acknowledge our blind spots. And right now, our field still relies entirely too heavily on adult cohort data. Applying adult diagnostic criteria to pediatric patients is highly problematic. Why? Because the pediatric nervous system is a moving target. Peripheral nerve growth and myelination are dynamic, ongoing processes that don't physiologically peak until a child is between 15 and 17 years old. Furthermore, interpreting subjective treatment responses, particularly regarding sensory deficits or pain in very young children, introduces a massive variable of clinical uncertainty. We simply cannot treat children as miniature adults in this space. So, I'll leave you with this final provocative thought to take away. We have these incredible emerging tools, like high-resolution nerve ultrasound, that offer painless, highly specific diagnostic insights. But until we conduct the large-scale, age-matched control studies required to establish robust, pediatric-specific anatomical baselines for growing nerves, how can we truly unlock the full potential of these technologies? The future of pediatric neurology demands that we bridge this gap, standardizing our baseline data so we can intervene earlier, more accurately, and far more gently for our youngest patients.